Hi, everyone. My name is Jean. I'm a dietitian and CNSC in the Chicago area. And today we're going to be doing another video for DNS about a really important topic, and I think one that a lot of us have, maybe not the most solid foundation on, and that is the use of vasopressors and the safety of providing tube feeding to patients who are on vasopressors. We'll go ahead and start by explaining kind of the vitals, or what we're looking at when we're discussing vasopressors and tube feeding. So the metric that we look at in the ICU for determining if blood pressure is adequate or not is the mean arterial pressure. So instead of, in the doctor's office where you're getting your blood pressure checked and they give you the systolic over the diastolic, in the ICU, we look at MAPS, so mean arterial pressure, because they're considered a better indicator of organ perfusion. So if we remember all the way back to physiology class, we know that the mean arterial pressure is approximately the product of your cardiac output and your systemic vascular resistance. So if we increase either the cardiac output or the systemic vascular resistance, or both, we will increase the MAP, therefore increasing organ perfusion and getting blood throughout the body in a better, more efficient way. We'll talk about a few types of pressors now, or a few various pressors that might be seen in the ICU. So in general, pressors are just medications given to raise the blood pressure. So they can work either by increasing systemic vascular resistance or cardiac contractility, which therefore increases your cardiac output, or really the amount of blood pumping that your heart does in each beat. So vasopressors are just kind of a general term, blanket term. It's used pretty often when describing pure vasopressors, but also inopressors and occasionally inotropes, which are all kind of, they're medications that all kind of have the same goal, but they act a little bit differently. So pure vasopressors act to constrict the blood vessels, thereby increasing your systemic vascular resistance, which is one part of that equation that gets you your MAP, or your mean arterial pressure. Vasopressin is a pure vasopressor, so it increases your systemic vascular resistance. Another one is phenylephrine, which increases your systemic vascular resistance as well. And it has a physiologic effect that's similar to norepinephrine, which is another pressor. Actually, that one is an inopressor. Those act to constrict your blood vessels, and they also act to increase your cardiac contractility, therefore increasing your cardiac output. So these medications actually act to increase both parts of the equation for the MAP, or the mean arterial pressure, which is the SVR and the CO. So norepinephrine increases your systemic vascular resistance. It causes venoconstriction, so it actually makes your blood vessels constrict, and it can increase cardiac preload, so it can have inotropic effects by increasing your cardiac output. Epinephrine is another one that has inotropic effect by increasing your cardiac output, and it also increases your systemic vascular resistance and causes venoconstriction like norepinephrine. Dopamine is kind of a wild card. Its effect is dependent on its dose, and that's about all that I understand about dopamine, so we're not going to really touch that one. I don't see it used very often, and it seems to kind of have fallen out of favor, at least according to some of the research I was doing preparing for this video. And then there's another class of medications called enotropes, which increase cardiac contractility directly, and you might see these specifically milrinone or dobutamine. And those aren't super relevant to us because they actually increase gut blood flow. Okay, so now we'll talk a little bit about why we care necessarily about specific pressors or inopressors. So three of the ones that we just mentioned, dopamine, epinephrine, and vasopressin specifically, actually negatively affect your GI blood flow by decreasing the fraction of your cardiac output that goes to the bed that perfuses your gut. So vasopressin specifically decreases GI blood flow, even if it's running at the same time as norepinephrine. So oftentimes patients will need more than one pressor, or they might be getting more than one pressor for different effects. Some pressors can alter your heart rate in addition to your blood pressure. So it's important to know, that even in conjunction with norepinephrine, which is one of the more benign vasopressors when talking about gut perfusion, vasopressin can still have negative effects. So that's something to kind of keep an eye on. Norepinephrine is kind of our friend here. It tends to minimally affect GI blood flow, so it's not as concerning as dopamine, epinephrine, and vasopressin. That's not to say we should count it out. We still have to account for it and check the dose, and we will go into that in a second in terms of figuring out what dose is considered safe. And then, as I just mentioned before, the inotropes like milrinone and dobutamine, those actually increase GI blood flow. So I usually don't really take those into account, and I actually don't see them used that often in my specific setting. I'm sure, some specific ICUs, maybe cardiovascular ICUs, would see those drugs used more frequently. So we just talked about, all the different classes of pressor medications and types of medications and what they do, but why do we care about them, right? As dietitians or nutrition support practitioners, why do we necessarily need to know that vasopressors act to, adjust blood flow and increase your mean arterial pressure? Well, it has to do with perfusion to the gut. So if in these patients that need vasopressors, it's usually because they're hypotensive. It might be because they're in shock of some sort, whether that's, cardiovascular shock or cardiogenic shock, neurogenic shock, whatever it might be. If it has to do with low circulating blood volume or low blood pressure, then there's possibly the existence of some ischemia in the gut due to periods of inadequate blood perfusion. So by feeding a gut that has ischemia already brewing, we can actually make that worse. And while intestinal ischemia from non-obstructive causes, so like from tube feeding while someone's hypotensive, it's not super common, but when it does happen, it's pretty dangerous and often fatal. So it's something that we definitely want to keep an eye on and try to see it coming and prevent it from happening. And of course, as we kind of talked about in the past couple slides, there's a variable effect depending on each pressor. It might improve intestinal blood flow, and a lot of them have a negative effect on intestinal blood flow. So it's important to know the difference so that you know which one or ones your patient is on and how that might affect your plan. So I think the one question that a lot of us have is, how do we know what is a safe dose for each vasopressor? And until recently, there really hadn't been a lot of research out there, and it's still not robust, but we do have some data now giving us specific numbers in terms of dosage for pressors and what might be considered safe or not safe. And how do we know they're safe? We use various definitions of nutrition tolerance. So we'll go into that in a bit in terms of, how do we know if someone's not necessarily tolerating their tube feeds while they're on pressors? So there's a lot of different studies with lots of different results, but I'm including some from this journal review that I found that includes specific doses and specific types of pressors, because I think that's the most valuable information to us. I know we all want numbers, right? Like a specific guideline as to this is when you feed, this is when you don't. So these studies that I'm reporting were collected in a review article in the Journal of Critical Care Research and Practice that's titled Vasopressors and Nutrition Therapy, Safe Dose for the Outset of Enteral Nutrition by Covello et al., and it was published in February of last year. So they reviewed 10 total articles, and 4 of these articles included specifics regarding dosage and which vasopressor they trialed or they tested or observed. So those are the 4 that we are going to review. The first trial that I pulled from this article was by Merchan et al. They were looking to evaluate tolerability of enteral nutrition in patients with septic shock who required pressors and determine what factors were associated with tolerance of enteral nutrition. So they used gastric residuals greater than 250 milliliters to indicate intolerance of enteral nutrition, which that's what they picked. Don't necessarily know if all of us would agree with that, but that's the metric that they chose. The pressor that they were using was a norepinephrine equivalent, and they were running it around doses of less than 0.14 micrograms per kilo per minute. So I know depending on what facility you work at, some places program their pressors to run in units per minute, and some run in units per kilo per minute. So make sure you're checking that before you write or before you use a number down for calculations, because that will make a big difference if it's dosed on weight or not. So in this trial, they did not find any mesenteric ischemia, so no gut ischemia. And their findings were reported that early enteral nutrition may be tolerated and safely administered in patients with septic shock who were adequately fluid resuscitated and who received doses of norepinephrine in less than 0.14 milligrams per kilo per minute, which I think that's supposed to say micrograms. Milligrams is a lot. Okay, our next trial we're looking at is Menkel et al. Their objective was to evaluate tolerability and safety of enteral nutrition in critically ill patients requiring IV pressor therapy. They used serum lactate as a symptom of enteral nutrition intolerance. They also looked at elevated gastric residuals, but it wasn't defined, and then occurrence of vomiting as well. So they used Levophed or norepinephrine in their trial and used it as a dose of 12.5 micrograms per minute. So this one was just a unit per minute, so it would be a variable unit per kilo per minute, depending on the kilogram body weight of all of the participants in this trial. So they found mesenteric ischemia did occur in their population at a rate of 0.9%. So less than 1% of their patients who are being fed on pressors at the dose of less than 12.5 micrograms per minute, 1% of them did develop mesenteric ischemia. So they reported their results as enteral nutrition is relatively well tolerated in patients receiving IV pressor therapy, equivalent to 12.5 micrograms per minute of Levophed norepinephrine or less. Tolerability was less likely in patients receiving higher doses of IV pressors and in those receiving dopamine or vasopressin, which makes sense based on what we just talked about earlier, that dopamine and vasopressin tend to have a negative effect on gut perfusion in comparison to norepinephrine, which seems to be a little bit more benign. The third trial we'll look at is Allen et al. Their objective was to review the effects of vasoactive substances such as pressors and inotropes on the GI tract, as well as their use in combination with enteral nutrition. So they didn't report their symptoms that they were using to define enteral nutrition intolerance, so we'll have to move on without that. They used dopamine, dobutamine, norepinephrine, epinephrine, phenylephrine, and vasopressin. So they used kind of all of the available pressors in the various doses listed. They didn't report mesenteric ischemia, so we're not sure if anybody experienced it or if they found anything significant regarding that. They did report the results that the use of vasoactive substances should not entirely preclude clinicians from using the enteral route to supply nutrition. The evidence suggests that enteral nutrition may be safely delivered to patients requiring vasoactive substances for hemodynamic support. So not super helpful conclusions in terms of dosing, but what it does tell us is that they're suggesting that we can feed patients who are on pressors, which has not always been the school of thought that was widely accepted. The last trial from this journal review that we'll talk about is from Wells et al. Their objective was stated to review the effects of vasopressors on GI blood flow, discuss complications associated with pressor use during enteral nutrition therapy, and to propose important considerations to determine the safety of enteral nutrition therapy in hemodynamically unstable patients who require pressors. So Wells et al. Defined enteral nutrition intolerance in their trial as 2 consecutive gastric aspirate volume or gastric residual volumes between 150 and 500 milliliters. So they, in their trial, were using kind of all of the pressors, so dopamine, epinephrine, norepinephrine, phenylephrine, and vasopressin. So they give dose specifics for the first four for dopamine, epinephrine, norepinephrine, and phenylephrine, as you can see on the slide here. They did not report any mesenteric ischemia that they found in their trial. And they concluded that in the majority of ICU patients, administering enteral nutrition into the stomach during the provision of low, stable doses of pressors with close monitoring for signs of intolerance or worsening hemodynamic instability poses very little risk for bowel necrosis. Okay, the second point of data that we'll talk about is from Paul Wischmeyer's research group. Dr. Wischmeyer is a critical care doctor out of Duke who does a ton of nutrition research. Highly recommend all of it. It's really great. I use a lot of it in clinical practice myself. So they looked at addressing enteral nutrition, how to feed patients who are on these vasopressor agents, in terms of specific pressors and then also dose. So on this table, he specifies the dose and the vasopressor choice, as well as how to identify, when is it safe to start feeding, how to start feeding, and what to look out for in terms of intolerance or a sign that maybe you need to kind of back off a little bit or hold tube feeds briefly. So in terms of from best for gut perfusion to worst for gut perfusion, they found that norepinephrine, or Levophed is brand name, that one was the best for gut perfusion, kind of in the same range as dobutamine, which is one of those inotropes. Then phenylephrine was next, followed by epinephrine, and then finally the worst for gut perfusion were vasopressin and dopamine. So the dosing is something that's not going to be consistent from facility to facility. Where I work, vasopressin is not titratable. It's just either on or it's off. So it's either running at 0.4 units or it's not running at all. But I've heard from other clinicians that at their facilities, they run vasopressin at a different dose, or they're able to titrate it. So that's going to be something that you're going to have to do specifically to whatever facility you work at. But one that is done in dosing that we can titrate on and off and up and down is, norepinephrine. So this is probably the most common pressor that I see used. It's usually the first line agent, at least at my particular facility. And ours run at micrograms per minute. So some of you might be lucky and have policies in place at your facilities where your norepinephrine runs in micrograms per kilo per minute. And that's good for you because then you don't have to do any math. And the Wischmeyer group found that anything less than 0.1 microgram per kilo per minute for norepinephrine was considered optimal or better and considered safe for feeding. Anything from 0.1 to 0.3 micrograms per kilo per minute was possibly acceptable, or maybe acceptable. And then anything greater than 0.3 micrograms per kilo per minute, it's associated with more significant risk of intolerance and intestinal ischemia, and then we should kind of hold off on feeding patients who exceed that dose. So note that those doses are micrograms per kilo per minute. So if you're like me and you work somewhere where your pressors run in micrograms per minute, all you have to do is divide that number by the kilograms of your patient's body weight, and you get micrograms per kilo per minute. So how do we know when to safely start tube feeding, right? So in addition to these dosage things, the research that Paul Wischmeyer put out suggests a few other kind of parameters. So we want to look at their serum lactate. If that's something that's being drawn and that your team is following on your patient, you want the lactate to be normalizing, either normal already or at least decreasing significantly towards normal. Of course, we want stable vasopressor doses or decreasing. We don't necessarily want to start tube feeding on someone who's requiring more and more vasopressors because that indicates, persistent hemodynamic instability. A few other things that, we can't really control as dietitians, so I don't necessarily take into account, but crystalloid fluid volume, which can lead to bowel edema if your patient's being resuscitated with liters and liters of, normal saline or something like that. That can cause bowel wall edema, which is not necessarily great for gut perfusion. They suggest starting slowly with feeding. So of course, trickle feeds or trophic feeds of 10 to 20 mils per hour. Um, and they say no post-pyloric feeding, so not necessary to bypass the stomach here. And of course, to advance the tube feeding slowly and monitor for signs of intolerance, whether you have, signs of intolerance defined at your facility that you work, or if you want to follow the suggestions here, they suggest monitoring for gastric residuals of over 500 milliliters, if you're checking them at all, of course. Notable abdominal distension, if your patient can communicate or indicate pain. If there's new abdominal pain, that's a sign of intolerance as well. If you see an elevation in lactic acid or serum lactate that isn't explained by something else, that could be an indication of the start of bowel ischemia. And then intra-abdominal hypotension or abdominal pressures. I'm not an expert in that, but I know that changes in that can also be an indicator that maybe it's time to kind of back off on the tube feeds. Okay, so wrapping things up, we've talked a lot about, different types of medications and the effects that they can have on whether or not it's safe to feed your patient or not. So I liked this figure from that journal review that I cited earlier that just discusses some take-home messages and kind of highlights of what we need to keep an eye out for. So the first thing is that enteral nutrition may be initiated when the patient is on stable or declining doses of vasopressors. So once your patient gets to a point where, the MAPs are kind of stable, maybe they're, above goal and the nurse is actually able to come down on the pressors, until that point is reached, it's probably a good idea to hold off on tube feeds. We don't want to be starting someone on nutrition who is having an increased demand for vasopressors, because that means they're still hemodynamically unstable. Additionally, we want to start off with trophic feeding. So trickle feeds, 10 to 20 mils per hour just to kind of stimulate the gut. We're not necessarily going to be providing a ton of nutrition with this, but we are going to be hopefully maintaining gut integrity. So we want to try that kind of as soon as possible in these hemodynamically unstable patients. But again, you got to use your clinical judgment to determine, whether or not you think that's the safe move to make. And finally, we need to make sure that we're monitoring our patients when we're starting enteral nutrition while they're on vasopressors. We want to monitor the dose of pressors. Are they adding more pressors? Are they able to come down from maybe 3 pressors to 2 or 2 pressors to 1? Are there any GI signs or symptoms that we need to be concerned about? Is there new distension, new vomiting? All these other things that, it's important to rely on communication between yourself and other members of the interdisciplinary team. Rely on your nurses. They're the ones that are with the patient the most often and can tell you like, hey, this patient's abdomen looks more distended than it was yesterday. Or maybe they had an episode of emesis overnight and they held the tube feeds. They're the person that's going to be giving you a lot of really helpful information if you're trying to determine if your patient is tolerating your feeds while they're on pressors. Okay, thank you guys for watching. If you have any questions, please leave them in the comments below and we will answer them to the best of our ability, of course. And we will catch you in our next video.